Very good evening to one and all. I am Arpita from the IGCP group. I would like to welcome you all to this very special session, which is the GOLD Update 2024 as we are celebrating the World COPD Day. And yes, to address this topic, we have someone with us who is a very eminent and well-known pulmonologist, none other than Dr. Prasanna Kumar Thomas, sir. It's an honor for us to welcome sir to our platform and to have him with us. To start with the topic, I would just like to welcome him and to introduce him to everyone. Sir has done MBBS diploma in tuberculosis and chest diseases, that is a DTCD. He has done MD in tuberculosis and respiratory disease and medicine. He is a senior consultant pulmonologist at Sir Ramachandra Medical College and MGM Healthcare Hospitals, Chennai. So, sir, with this very brief introduction of yours, I would now welcome you and would request you to please start with the topic for today. Over to you, sir.
Thank you, Arpita. Thank you very much, and a very warm welcome to all personnel who have joined on this webinar. A very warm good afternoon to one and all. We will talk today about, I thank IJCP for having given me the opportunity to be here. We'll talk today about the 24 gold updates. I think one needs to understand that the 25 gold updates are already out about, say, probably 4 or 5 days ago. There are some small changes which we will talk about at the end. Ultimately, I think there is very little difference between the 24 and the 25, except for the small changes which we shall discuss at the end of this presentation. So we begin by saying that COPD is a heterogeneous condition characterized by chronic. So the definitions have been reversed, and I think that's important. It's been revised. Pre-COPD, they've talked about pre-COPD, respiratory symptoms and or more structural lung disease. And PRISm, of course, is the term where you have identified those with normal ratio but abnormal spirometry. So I think they've looked at normal people, abnormal spirometry, and normal people. And I think we've looked at a lot of things in this definition. It's important that this definition has been revised. 7% of adults are estimated to have COPD second leading cause of death. Heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, sputum production due to abnormalities in the airways. We understand that other causes of chronic cough, of course, are lung cancer, tumor, tuberculosis, bronchitis, extrathoracic could be chronic allergic rhinitis, postnasal drip syndrome, UAC, upper airway cough syndrome, gastroesophageal reflux. The trajectories over the life course, and I think this is a very interesting addition to 24. And this is being carried over in the 25 guidelines, where they have talked about trajectories in the pulmonary function, some from birth to the termination of life in patients with COPD. So they've talked about childhood, talked about puberty, talked about adulthood, and then slow aging, the premature death that's seen in patients with COPD, with chronic respiratory failure and poor ventilatory function. But I think it is very important for us to understand it, especially in premature children, for example, with low lung capacity and lung growth. I think the incidence of things like COPD is very much higher than in other groups. So I think this question of FEV1 trajectories over time is something that's carried on from 24 to 25. So the etiophenotypes of patients with COPD, genetically determined is COPD-G. COPD due to abnormal lung development is COPD-D, which is developmental. Environmental COPD, cigarette smoking is COPD-C. Biomass and pollution is COPD-P, which is pollution. COPD due to infections is COPD-I, like you will get infections in bronchitis, childhood infections and things like that. The overlap between COPD and asthma is COPD-A, and COPD of unknown cause is COPD-U. So there has been a tendency to try and short classify these things into smaller things so that it leads to better understanding. They've also talked about chronic bronchitis, brought this terminology in after a very long time, possibly because of the overwhelming presence of patients with bronchitis and basically infective bronchitis in these patients. So chronic bronchitis, defined presence of expectoration, cough, found in never smokers. Gastroesophageal reflux is also associated disease of chronic bronchitis. Radiographic manifestations of mucus plugging will be present in persistent patients with COPD despite a lack of chronic bronchitis syndrome. So ABE assessment, a paradigm change from the ABCD assessment. If at all there is one change in the 24, this is the most important change. We had A, B, C, D, and E. Now the C has been off and been replaced by the E. The grade 1, of course, continues to be the same, which is classified according to the gold and the percentage of the FEV1 predicted. Greater than 80%, 50 to 79%, 30 to 49%, less than 30%. Then you look at exacerbations, and of course, you look at the MRC score that is being seen. You have group A, group B, and group E, for example. E in my book, I think, stands for two things that I can think about. One is eosinophilia, the fact that there are a lot of these patients who are eosinophilic. Eosinophilia simply means that they are steroid sensitive, and they probably have a high phenol attached to the eosinophilia. And the other, of course, is that the group E is a group that is constantly associated with exacerbation, as we have seen here, the question of exacerbation history. So the gold ABE assessment tool, spirometrically confirmed diagnosis, assessment of risk factors, and the moderate exacerbations we've seen before, I think is again very important. So look at modified initial pharmacologic treatment. Group A would be a single bronchodilator. Whether you want to use a LABA or a LAMA or a combination of a LABA-LAMA is something that's left to your discretion. Group B, of course, the recommendation is to use a LABA-LAMA. And group E would be to continue with the LABA-LAMA. And as I said, if your blood eosinophil is greater than 300 or you are a constant exacerbator, you have the option to add the ICS along with this and make this triple drug therapy, LABA-LAMA ICS. And I think that's something that we'll be looking at over a period of time. So management cycle would mean that you review the symptoms, look at dyspnea and look at other causes, adjust the scale, and then assess the pharmacologic technique, especially the inhaler technique, the rehabilitation and self-management that you're looking at. Now, pharmacological treatment is looking at two clear domains. And I think this is very interesting. This is carried over into the 25 guidelines that I have seen. You have dyspnea on the one hand and exacerbations on the other hand. Dyspnea is the patient's discretion where they use the LABA-LAMA or use a LABA-LAMA ICS depending upon which inhaler device or molecules. Exacerbations would mean that you start with LABA-LAMA and add the ICS as quickly as possible. And at the fag end of the spectrum here, you have roflumilast and azithromycin, preferably in former smokers. So it is very important for us to understand that there are two clear verticals that they've come up with here, dyspnea and exacerbations. And I think we need to be conscious of that as we look at this. So looking at the management of COPD, look at diagnosis, look at initial assessment from GOLD, look at the CAT score, exacerbation history, smoking status. Initial management, of course, would be smoking cessation, vaccination, active lifestyle. Then you have a review of the symptoms, need for oxygen, need for NIV, start with a single drug, which is a LAMA, and then go on to a LAMA-LABA, and then go on to an ICS LABA-LAMA, and then probably add roflumilast and azithromycin, depending upon the condition that you're looking at, and you finally adjust therapy. So the EMAX randomized trial of LABA-LAMA is superior to LAMA, and I think this is something that we need to understand. The fact that the LABA-LAMA is a very, very clear option, which is much, much better than the LAMA that's been used in as monotherapy. To change from baseline trough FEV1 at week 4, week 24 was 66 ml greater with umeclidinium vilantrol, which is LABA-LAMA, versus umeclidinium and salmeterol, and safety profiles were very similar in both. So the IMPACT trial showed that once daily single inhaler triple drug versus dual drug therapy. Triple drug therapy showed a definite benefit. We've already seen triple drug therapy in Group E when we discussed the groups of COPD. We understand very clearly that umeclidinium, vilantrol, and fluticasone, which is triple drug as such, was markedly superior to the dual drug therapy that we had with the LABA and the LAMA. The ETHOS trial where triple drug was superior to dual drug therapy and including the rates of exacerbations. You're looking at exacerbations, you're looking at mortality, intention to treat, weak since randomization, but I think in every way, I think triple drug therapy is superior. So exacerbations, it's very important to sort of look at exacerbations and look at the so-called Rome proposal, treatment at the point of care and site of care, outpatient, inpatient, which may really dictate the way that we treat our patients with COPD, whether the dictation will mean you treat them as outpatient or you treat them as inpatient, depending upon the clinical severity of the exacerbation, but also by the structure of different health systems and the availability of health facilities at that point of time. Goal 24 now discusses several retrospective studies that confirm the validity of the Rome proposal to predict mortality. So your point of care, as we look at it, your site of care really determines the mortality in the long run. And I think we need to understand the classification of a stable patient in the A, B, or E groups to guide initial pharmacologic treatment must still rely necessarily on the history and recall previous diagnosis. So follow-up treatment is revised dyspnea, LABA, and then you have the LABA, consider switching inhaler device or inhaler molecules. Then, of course, we said we've looked at these two domains of dyspnea and exacerbations. We've already looked at it. You look at blood eosinophil of greater than 100 or a blood eosinophil of greater than 300, you go straight for the ICS LABA. Whereas on the other hand, you can do with the LABA and then add the ICS as they come on, and finally end up with roflumilast and azithromycin. They have added another PGT4 inhibitor. I just forget the name of the drug in the new 25 guidelines. And also, there is also very strong mention of the biologic dupilumab for that matter in the 2025 guidelines. Dupilumab is very classically mentioned in these guidelines, in the 25 guidelines as an option that's used in patients in group E, where you have severe exacerbations and very poor lung function. And that's something that's being looked at as such. So role of ICS and LABA relook, patients under treatment with ICS LABA, patient with COPD and no features of asthma has been treated for a while. ICS LABA well controlled in terms of symptoms and exacerbation, continuation with the ICS LABA. Yes, if the patient has a further exacerbation, treatment should be escalated to LABA ICS and B major symptoms being switched as such. So I think the modified dyspnea scale, the MMRC scale, grade 1, grade 2, grade 3, grade 4. I think this is too basic to talk to an audience like this, but we need to understand that the MMRC score is the one that we really base our ABE classification on. And I think it's important for us to understand that and also understand the patient scores that you're looking at here in these patients, looking at various entities. This is an entity that can be used as the patient's wait to be seen for consultation. It can be used in the consulting room where you get a fairly good idea of how severe the patient is and how severe the COPD is for that matter. Factors to consider when adding ICS to long-term bronchodilators. The question of ICS, and I think is something that's very important. The differential diagnosis, I think, is important. COPD and asthma, always difficult to differentiate. Congestive heart failure, very, very important to look. The simple chest X-ray will tell you that a basic presence of cardiomegaly and increased vascular markings at the base, the presence of what we call pulmonary venous hypertension will tell you that you're dealing with congestive heart failure. Bronchiectasis is something that you need to understand. If you suspect bronchiectasis, probably the best investigation to do would be a CT scan to tell you clearly that you have additional bronchiectasis. Tuberculosis, I think, never say no to tuberculosis in this country. Tuberculosis is always a yes, and I think if there's any suspicion of tuberculosis, you need to rule out tuberculosis before you go ahead and treat the COPD as we look at it. Obliterative bronchitis and diffuse panbronchiolitis are other entities that you're looking at. So revised definition of exacerbation, defined as an event characterized by increased dyspnea and or cough and sputum that worsens in less than 14 days, may be accompanied by tachycardia and tachypnea, and is often associated with increased local and systemic inflammation caused by infection, pollution, or other insults to the airways. I think there is one thing that we need to understand when we talk about exacerbation. Not all exacerbations are infective exacerbations. There are a very clear percentage of patients who come with non-infective exacerbations. And that's what is being looked at here when you looked at pollution or other insults to the airways. Like, for example, if you're in Delhi and you're exposed to the pollution in Delhi, I think you obviously will be looking at an occupational element that is contributing to your exacerbation in patients with COPD. So I think it's very, very important to consider non-infective causes of exacerbation with COPD. So diagnosis and assessment of exacerbations, complete thorough clinical assessment for evidence of COPD and potential respiratory and respiratory symptoms, assess, evaluate, and establish the cause of the event, whether it's viral, bacterial, environmental, otherwise. So focus on therapeutic interventions to reduce pharmacologic mortality, reduce COPD mortality. Pharmacologic therapy, recent evidence emerged from two large randomized trials where we looked at the triple drug therapy, the ethos and the impact, the LABA-LAMA ICS, and all-cause mortality compared to the dual inhaling bronchodilator therapy. Non-pharmacological interventions like smoking cessation, pulmonary rehab, long-term oxygen therapy, non-invasive ventilation, NPPV, and then, of course, lung transplantation and lung volume reduction surgery in the form of LVR. So there are multiple modalities of therapy that you're looking at. Pulmonary rehab is very important. The 25 guideline has a separate section on pulmonary rehab. And I think it's important for us to understand that rehab is a thing that you need to start from day one. Rehab is not restricted to people who have very severe COPD. But I think the question of movement and pulmonary rehabilitation needs to begin with even in patients with a mild to moderate COPD so that they have a much better and longer life without any problem. So evidence of smoking cessation and mortality, I think this is a no-brainer. The fact that you need to stop smoking is absolutely important and is very directly connected with the mortality that you have in patients with COPD. So CDC recommends 1 dose of 20-valent pneumococcal vaccine, unfortunately not available with us. PCV20 or 1 dose for the 15-valent, again not available with us, followed by the 23-valent, which is available to us. The only two polysaccharide, the only two pneumococcal vaccines that we have are the 23-valent polysaccharide vaccine and the 13-valent vaccine that you're looking at. So the PSV23 and the 13-valent vaccine. So I think these are the vaccines that we need to use. So there is a large scope for vaccination, which is being carried on to the 24-25 guidelines as well. Prescription for supplementary oxygen to patients with COPD. Arterial hypoxemia is defined as a PaO to about 55. Prescribed supplemental oxygen titrate to keep the SaO to around 90. Recheck in 60 to 90 days to assess if supplemental oxygen is still indicated, if prescribed supplemental oxygen is effective. Issues related to inhaled delivery system. And I think this is again very interesting in the sense that this is the first guideline that's talked about inhalers. And I think it's important that we give them the credit for talking about inhalers, because I think this is important and this is being carried over to the 25 guidelines as well. Ability to use delivery system correctly using the teach pack approach, patients being asked to demonstrate and show how they use the inhaler, the pharmacist, physician, physiotherapist, and the nurse-led interventions. Digital inhalers could contribute to improved adherence in inhaler technique. Selection process should aim to identify the optimal device for each patient. I think the question of optimal, I think, is absolutely paramount, vital. If there is one entity in the selection, I think it's a question of not the best device for the best patient, but the optimal device for the optimal patient, I think, is the way that I would look at it. What is my optimal device for my patient? I think that's more important than saying that one inhaler is better than the other. It's like saying that your father is bigger than my father or my father is bigger than your father. So I think we need to understand the final choice should be made jointly by the prescriber and the patient, taking into account patient attributes, patient's abilities, goals, and preferences. Systemic process should be used to select a delivery system and ensure that the patient can use it properly. So basic principles for appropriate inhalation use, availability of drugs, number of devices should be minimized for each patient. I think it's better to use a single device if it's possible, and that's where triple drug therapy really makes a very big difference. Shared decision making is the most important strategy for inhalation device and choice. Patient's cognition dexterity and strength must be taken into account. Dry powder inhalers are appropriate only if they are able to breathe deeply and forcefully. For patient unable to use MDI with or without the spacer, HDI nebulizer should be considered. Please don't hesitate to use nebulizers in patients with COPD who have poor coordination and poor inspiratory capacity. Other factors should include size, portability, and cost. Physicians should prescribe only devices, and other members of the carrying team they know how to use. The key points for inhalation drugs: importance of education and training in inhalation, I think, is important. Maintenance of inhalers, maintenance of nebulizers for that matter, is very, very important. Patients need to be taught how to use the inhaler and how to maintain the inhaler, how to use the nebulizer, and how to maintain the nebulizer. It is essential to provide instructions and to demonstrate proper inhalation technique when prescribing a device, to ensure that inhaler technique is adequate, and to recheck at each visit that patients continue to use their inhaler regularly, correctly. Inhaler technique and adherence to therapy, I think, is extremely important in these things. So basic principles for available inhalers: device type should be switched, should not be switched in the middle, and I think we need to understand the dry powder inhalers. The use of CT, for example, this again is carried over into the 25 guidelines, differential diagnosis, where you use a CT in these patients. What will a CT tell us in patients with COPD? It will give us causes for excessive cough if you're looking at bronchiectasis, if you're looking at hyperinflation and bullous formation. It will look at you'll get a cause for non-response to therapy. Endobronchial lung volume reduction surgery, endobronchial valve therapy as a concern for patients who exhibit post-bronchodilator FEV1 between 15 and 45. Annual dose of low-dose CT is recommended for lung cancer screening in these patients. So CT to diagnose comorbidities like emphysema, bronchiectasis, interstitial abnormalities, coronary artery disease, pulmonary artery enlargement, descending aorta, hiatus hernia, steatosis, and other things that you're looking at. So systemic detection of 10 CT diagnosed comorbidities, most of which were not detected clinically, provides information of potential to use patients and clinicians, and caring for them with a CT, I think, is important. Interstitial lung abnormalities have introduced a term called ILA, are often found in patients with COPD. A new analysis of patients with COPD, for that matter, I think, shows that. Oh, I'm so sorry. I think I missed. Yeah, ILA, and I think yeah. So ILA associated with suspected interstitial lung disease. Evidence in supporting a reduction of mortality with pharmacotherapy and non-pharmacotherapy in these patients. It is important to understand that triple or dual drug therapy will produce a definite pharmacologic benefit. Non-pharmacologic benefits are produced by smoking cessation, pulmonary rehabilitation, long-term oxygen therapy, non-invasive positive pressure ventilation, and of course, in very, very selected cases, of course, you can have LVRS, where you have upper lobe emphysema and low exercise capacity in these patients. Pulmonary rehab and self-management and integrative care in patients with COPD. Pulmonary rehabilitation improves dyspnea, health status, and exercise tolerance, reduces the hospitalization among patients who had recent exacerbations, and education and self-management has been shown to be effective. Self-management intervention, integrated care programs, again, are very effective. Focus on tele-rehabilitation. And I think this is something that we look at very seriously since the days of COVID, for example. We've really had tele-consultation and tele-rehabilitation. Patients who are discharged from hospital can be taught pulmonary rehab, and you know that they can be followed up by tele-rehab in these patients. By some sort of visual methodology, standardization of a delivery platform, no single best mode of tele-rehabilitation therapy, tests performed remotely allowing for accurate diagnosis, information on suitable variations in components and timing of interventions, and evidence about duration of benefit. Studies have suggested that tele-rehab is safe and has similar benefits to those of center-based PR across a period of time. So this is again newly added here, intervention and surgical therapies for patients with COPD, whether the dyspnea would be bulla, emphysema, giant bullectomy, airway stenting, EBV, coil, thermal vapor ablation, lung sealants, LVRS, of course, lung transplantation, targeted lung denervation, nitrogen cryospray, rheoplasty, and surgical bronchoscopic techniques in these patients. So lung surgical treatment, bullectomy, lung volume reduction surgery, and lung transplantation. Bronchoscopic interventions would mean excessive dynamic airway collapse, EDAC, disease of major airways causes apparent collapsibility on expiration. Symptoms include dyspnea. Nitrogen cryospray is another modality that will gain prominence over a period of time. It's just being in the nascent stage at this point of time. Lung denervation means that the goal is to stop parasympathetic nerve signals to and from the lungs. Water-cooled catheter with radio frequency energy is used to parasympathetic nerve transmission in these patients. Bronchoscopic interventions to reduce lung hyperinflation, patients with emphysema, LVRS, valves. I think these are very important bronchoscopic interventions, and they are being dealt with extensively in patients in both the 24 and the 25 guidelines. This is an overview of whatever we've looked at. So greater focus in the management of mucus hypersecretion. This is another entity that is new to the 24. We have started looking at mucus hypersecretion, reducing the overproduction of mucus, decreasing mucus hypersecretion, facilitating elimination of mucus by increasing mucociliary transport, decreasing mucus viscosity, facilitating cough mechanisms, smoking cessation. Smoking cessation can improve cough by improving mucociliary functions, liquid nitrogen meter, cryospray. So new comorbidity added has been frailty and polycythemia. This is again very important. Frailty can be defined in the presence of 5 components: weakness, slowness, exhaustion, low physical activity, unintentional weight loss. Polycythemia, secondary polycythemia, has long been recognized to be one of the major manifestations of chronic anemia. 6 to 10% of patients where you have defined as a hemoglobin which is going high in these patients with 17 or more grams per deciliter in males and 15 in females. Anemia and periodontitis in dental hygiene. There is an association with periodontitis in dental literature and hygiene. This is something that really needs to be looked into. Is common in COPD and requires treatment in its own right, which may lead to a reduction in exacerbations. Anemia, I think, is another important comorbid that we look at in these patients, and we need to look at it. COVID-19 and COPD, a lot is being said about COVID-19. You look at mild COVID-19, look at the dyspnea and infiltrates. We are still looking at certain shadows that are left over from the COVID-19, especially in patients who have the long COVID syndrome, and the production of things like ARDS and convalescent COVID over a period of time. So even now, if you have a patient with the respiratory symptoms and the history of COVID, for example, in the past, it may be worth getting a CT scan in these patients to try and assess whether they are impacted with the long COVID syndrome that we're looking at. So discharge criteria and recommendations for follow-up, full review of all clinical and laboratory data, check maintenance, therapy and understanding, reassess inhaler technique, ensure understanding of withdrawal of acute medication, assess need for continuing any oxygen therapy, provide management plan for co-counseling, and enable follow-ups in these patients as such. Biologics, I think the previous studies of mepolizumab and benralizumab yielded inconclusive results. They showed a clear clinical effects of dupilumab, and these have been greatly exacerbated, greatly emphasized in the 25 guidelines that we've looked at. The fact that you have dupilumab as a very clear option in patients with eosinophilia of greater than 300, in spite of triple drug therapy, who suffer exacerbations and symptoms of chronic bronchitis. Goal 24 acknowledge these results pending confirmation of studies. If confirmed, this would finally open the possibility of using biologics, and that's what the Goal 2025 has really told us. Summary of the key changes: new definition for COPD, a new section on chronic bronchitis, additional information on screening and case finding. ABCD tool has been revised to the ABE assessment tool. new information on imaging and computer tomography, vaccination recommendations for people with COPD, further information on therapeutic interventions to reduce COPD mortality, and new table has been included. A new definition of COPD exacerbation. Devices, I think, have been looked into. A section on tele-rehab, a section on intervention and surgical therapies, new information about choice of inhaler device, information and figures outlining the pharmacologic treatment, the sections on COPD and comorbidities. The 25 guideline has a couple of other interesting observations. The first observation that I could really think about is climate change and COPD. There is a section on climate change and COPD. There's a great emphasis on dupilumab. There's an emphasis on triple drug therapy, very strong emphasis on pulmonary rehabilitation. So I think we need to look at all these things, a lot of things about dupilumab and epidostine and things like that. So I think it is important that we look at these things as possible therapeutic options in the future. So these are the basic changes in the goal that we're looking at. The goal key changes would be interstitial lung abnormalities, blood eosinophil, targeted screening, pre-bronchodilator spirometry, hyperinflation, the PRISm, pharmacotherapies for smoking cessation, inhaler selection, vaccinations, biologics, and smoking cessation. Religion is something that is left over from the infancy of our intelligence. It will fade away as we adopt reason and science. And I think that's the most important thing. To adopt reason and science as our guidelines, I think is so very important when you look at the 24 guideline and also at the 25 guideline, which is again beautifully written and well documented. The fact that the guidelines are guidelines and they should help us to enable us treat our patients better and make life more easy both for our patients and for us. Thank you very much for the patient listening. Good evening. There any questions?
Yeah. Yes, sir. Yes, sir. There are a few questions. Just give me a second. I will read them out to you, sir. So the first question is, how has the classification of COPD severity evolved in the 2024 updates?
The classification of the severity is that they dropped the group C and put up the group E. Group E, as I told you in my book, looks at two things. It looks at an exacerbating phenotype, number one. It looks at people with eosinophilia, number two, especially a eosinophil of around 300. And I think it's important for us to understand that E could stand either for eosinophil or for exacerbation. So the exacerbating phenotypes have been grouped together into one section where they've called it group E. So I think it's important for us to understand that they've changed the whole gamut of classification when we look at the 2024 and the 2025 guidelines.
Right, so moving on to the next question. What are the recommendations for initiating biologic therapies or novel agents for COPD exacerbation?
The only biologic that's approved for COPD is dupilumab. And there has been a mention of dupilumab in the 24 guidelines and extensive reference to dupilumab in the 25 guidelines. And I think it is very, very interesting because we'll be looking at dupilumab very, very seriously because it acts extremely high on the axis of the attractant chemokines that we're looking at in these patients. Because it acts high, there are a lot of expectations from dupilumab. And we understand from the Western literature and the studies that have been associated with dupilumab is that dupilumab is extremely effective. And we're looking forward to using dupilumab in a big way and trying to see that our patients benefit from that. The only problem with any biologic, of course, would be something called the COST, which is the cost. I think we need to look at dupilumab in that way only. But we have a lot of expectations from dupilumab.
Right, sir. Thank you so much for answering this query. The next question is, how do the 2024 guidelines integrate the use of digital health tools and remote monitoring in managing
Good.
COPD?
I think remote monitoring and monitoring patients with COPD would be three things. One, monitoring compliance. You can monitor compliance by digitizing your inhalers, for that matter, trying to look at it over a period of time and have the digital counter with the Bluetooth and things like that, which can tell you whether your patient is compliant or non-compliant. Number two would be tele-rehabilitation, teleconsultation. These things are very, very important. So all these digital media platforms that we have created for ourselves will make a very huge difference in these patients with COPD. And I think we need to utilize them and use them over a period of time. Tele-rehab has now become a very established modality and an established tool in these patients, as is teleconsultation itself, for that matter.
Right, sir. Moving on to the next question. Are there new recommendations for the prevention of exacerbation in high-risk patients?
The recommendation for exacerbation, of course, would be things like smoking cessation, for that matter. I think it's very important to look at smoking cessation. It would be very important to look at vaccination in these patients, especially to add vaccines like the Tdap and the shingles vaccine, for example. These are vaccines that are recommended along with the other vaccines that have been recommended, which is the pneumococcal and the influenza vaccine. So I think it's important to look at the Tdap and the shingles vaccine also here. Vaccination would be an important entity. Early start of oxygen therapy and early start of pulmonary rehabilitation would be very important entities when you look at exacerbation. And of course, pharmacotherapy. Early initiation of the right pharmacotherapy, the choice of either to use the LABA/LAMA or switch to the LABA/LAMA ICS, I think would be an important entity to look at in these patients. The presence of the combination of the ICS and the ultra-LABA, for that matter, in the form of indacaterol and bilanterol, I think has produced a huge difference in these patients with COPD that will be looked at with a great deal of interest. So we'll be looking at it also. We'll be looking at triple drug therapy. And of course, we'll be looking at dupilumab as we look at things down the line.
Thank you, sir. One last question for today. How do the updates incorporate findings from recent clinical trials into clinical practice?
So basically, I think it's the ethos and the chronos and the impact that have really impacted the fact that you have the 24 and the modified 25 guidelines that we have looked at in these patients. So I think that's really where you're looking at. You're looking at the fact that there is enough literature to tell you that the recommendations that are made in the guidelines, I think, are good in the sense that they reflect the science that is practiced all over the world and the trials that are held the world over. So we sort of benefit from the fact there are thousands and thousands of patients who have got onto these trials. So these trials are time tested. Number one, they are also tested in a huge number of patients. And they also call for the fact that the more the number, more the safety. The safety is very, very important, and the safety is directly proportional to the number of patients who are enrolled in trials. So I think it is important to look at that as well.
Right, sir. So these were all the questions for today. Thank you so much for answering all them in detail. And so with that, we would like to conclude the session. But before that, I would like to thank you from the bottom of my heart, sir. Thank you so much for taking out your time and for making effort into making such a valuable presentation. So thank you so much, sir. And I would like to thank all the audiences for joining in, for putting up their queries and making it a successful session. Thank you so much, sir.
I thank IGCP for giving us the opportunity to get together. Thank you very much. Good evening and God bless you. Thank you.
Thank you, sir. Thank you.